I want you to look at the screen there. Just look at the video which is playing. Look at that video. Then may I please have comments on what is it you can see on the video? What can you see on the video? Comment in the chat box. I will not move from this slide until I get some comments on what we are seeing on the video. What is it we can see, guys? You can see the video there. What is it we can see? Oops. What's happening? Okay, the video is back. What is it we can see on the video? Any comments on the chat box? Any comments on the chat box? What is it we can see on the video? The teammate Sally, what can you see on the video? Or we can say Parenyatwa, what can you see on the video? Okay, while you are thinking, I'm going to go to the second video. I'll go to the second video. Continue thinking about this video, but I'll play the second video. What's happening here? Yeah. There is the second video. Again, what can we see on this video? That's the second video. What can we see on the video? I'm waiting for comments. Parenyatwa, and Salim Gabe, anyone to comment? That's the second video there. I played with the first one. Let me go back to the first one just in case there may be somebody who was not in the meeting. Then this is the first video. Oops. Let's play this video. So that's the first video there. I'm waiting for comments in the chat box on what people think of these two videos. What are we looking at, and why are we doing what we are doing here? Why are we applying color? What is it we are trying to demonstrate on the scan? We're trying to demonstrate what? First video, second video. I don't know if I should proceed, because if people do not have even an idea of what is in the screen, I'm not sure if proceeding will be the right thing to do. Any comments? There's one comment. Let's see, where is this comment from? So Mr. Kumbula is saying placenta with color mapping of the umbilical cord insertion. Yes, that's one of the things we are seeing there. What else are we looking at? Yes, the first video is showing us what he said, but the video is showing us more. The video is showing us more than just umbilical cord insertion. Any other comment? Let's see. Yeah, the answers are coming now. Marginal cord insertion. Yeah, indeed, the first video, there's marginal cord insertion. Then the TVS, with Shem Makwaza. Well done. So Shem Makwaza is saying the second video is demonstrating vasa previa. Excellent. So yeah, so the second video is demonstrating vasa previa. The first video is more than just cord insertion. Let's go to it. So this is a case of a lady we had placenta, bilobe placenta. If you look carefully in the video, you are going to see that we do have a lobe. Let me put on a pointer there. Oops. Laser. So you are going to see that there is a placenta lobe here, and the main part of the placenta where the cord is inserting is posterior, while this one is more appears anterior on the image. What we are looking at are the communicating vessels. These are the communicating vessels between the two, because this lobe here doesn't have is not getting doesn't have its own kind of cord insertion. So it's the two communicate via this communicating vessel, which is running on the surface, as you can see. Why did I put this image? I've put this image to remind everyone that whenever you identify bilobe placenta, don't walk away and celebrate and say, oh, I've identified a bilobe placenta. You need to confirm the communicating vessels. You want to know where the communicating vessels are running through. In this case, let me say it's probably the good kind of bilobe placenta where the communicating vessels are running on the surface and far away from the cervix. So these are communicating vessels in a case of a bilobed placenta. So whenever a bilobed placenta is reported on, the communicating vessel should also be communicated or to be reported. So you will write that you have seen a bilobe placenta. The main part of the placenta is either anterior or posterior or lateral, while the smaller part of the placenta is either posterior, anterior, or what? The communicating vessels on the upper part of the uterus, or the lower part, or the lateral part of the uterus, and are far away from the lower segment, or far away from the internal os. That is very important to communicate that information, and to also tell the patient so that they know they have a bilobe placenta. The question is, why should you be telling the patient that they have a bilobe placenta? Because if they are going to be delivered natural, the main lobe of the placenta will obviously come first, because it's the one which where the umbilical cord is. But the membranes between the two may avulse, and the other lobe may remain inside. You know that our midwives examine the placenta for completeness. This placenta, for sure, it will be complete. There is no way that the placenta will not be complete, because the other part is just membranous part, which communicates the two. So the placenta will be reported as complete, but there will be a lobe that will be stuck inside the mother, the uterus, and the woman will continue to bleed. These are the cases whereby you hear people saying the placenta was complete, and the patient will end up being taken for hysterectomy only to find placenta tissue inside. So that's a bilobe placenta. So the bilobe placenta, whenever you pick it up, also inform the patient so that the patient can remind whoever is going to deliver them, because the delivery part is very hectic, so that people overlook. For example, for those who work at Sally, you know how Sally is. Sometimes it's super busy, and people deliver people they don't even know. They just find a woman delivering, they deliver without even looking at the history. People don't even look at the notes. All they are doing is to receive the baby, because the baby is about to come out anyway, whether you are there or not. The baby is either it's going to be on the floor, or you receive the baby. So it is those moments whereby these kind of cases are going to be missed. So if the woman is informed, then she can remind the health worker that there is another lobe. My placenta is in two parts, and those two parts have to be seen to save the woman from avoidable PPH and a lot of and other morbidities. Then the second one, who got it right? Shem was right. Shem Makwaza was right to say this is a vasa previa. Let me play the video. So this again was another case of bilobe placenta. Oops. How can I play this? Yeah, there we are. So this was another case of bilobe placenta. In this case, where the posterior and the anterior part of the placenta. Fortunately for this lady, we picked up this vasa previa when she came for a 20-week anomaly scan with us. So we were serially monitoring her, and this is the scan we did on her 34 weeks. So you can see here the vessel, the communicating vessel, the vessel that communicates between the two placentas running through the cervix. This is the cervix. We're just putting pressure on it, but this is the cervix here. You can see the canal with the mucus plug inside. So that's the cervix, and the vessel is running across the cervix, as you can see there, the communicating vessel. This is why when you do internal scans, especially the guys in the preterm there, always remember to put on color and check for vessels that traverse the cervix. That's the only way you can screen for vasa previa and improve the detection, because most vasa previas are missed. These are the cases that come into labor with bleeding torrentially after rupture of the membranes. So when you are doing the internal scan, it's unfortunate that right now at Sally, we're having a challenge with the probes there for the Volusons. So the machines they are using doesn't have a TVS probe. But the TVS probe doesn't have the color. But when you are working with the machine with the color, always try to put on the color Doppler to see if there is a vessel that is traversing the internal walls, because that's the best way to improve the detection rate of vasa previa. So that's vasa previa. I will take you briefly through vasa previa so that we can get a little bit more theoretical background. It is as common as 1 in 3,000 pregnancies. That means definitely we have scanned some women in our units, because all our units to date have scanned way beyond 3,000 pregnancies. So if you haven't seen it, it means you were not looking for it. You missed it somehow, because you were not putting on the color Doppler whenever you are doing the cervix. Then in terms of the diagnosis, I think I showed you the videos, how we diagnose it. That is the umbilical vessels, which are unsupported by either the umbilical cord or placenta tissue that traverse the fetal membranes of the lower segment above the cervix. So that is what we see, like I showed you on the video there. Transvaginal ultrasound and color Doppler are necessary to make the diagnosis. I'm just emphasizing this point because there are still people who don't believe in transvaginal scans, or people who believe that transvaginal scan is not necessary to assess a pregnant woman. But I want you to know that you can't run away from the transvaginal ultrasound, because transvaginal ultrasound is very vital in pregnancy assessment. This is one of the its utility to try and increase the detection rate of vasa previa. Vasa previa is fairly common in obstetric terms, because when you are saying it occurs in 1 in 3,000, what it means is that in Zimbabwe, we have a potential of having 100 and something cases a year, because we deliver 400,000 women a year. So that is that potential that there are 100 something cases that happen every year of vasa previa in our country. So it's not an uncommon condition. It occurs with in association with a filamentous condensation. I think the first case, the first video I showed you was more marginal condensation, but whenever you see filamentous condensation, try to track the vessels and see where they travel through. It also occurs in bipartite placenta, which is a bilobe placenta, or a subcenturiate lobe. To me, probably these terms are more or less the same, but people just decide to complicate things. A bipartite, subcenturiate lobe, but to me they are more or less the same. It's a bilobe placenta with 2 lobes. Right. So the risk factors are multiple pregnancy, IVF conceptions, and also low-lying placenta in the 2nd trimester. So investigations, transvaginal sonography with color Doppler is the way to go. Then follow-up is serious scans every 2 weeks after 26 weeks to monitor cervical length. Why are we monitoring cervical length? With the more the shortening, the more the risk that there will be tears around the area of the cervix and the woman will bleed. If there is evidence of shortening and the cervix is now below 25 millimeters, or there's a rapid shortening, for example, you may see a woman with a cervix of 45, in 2 weeks, your cervix is 29. There's no way you can allow that woman to say, go home and you are fine, your cervix is above 25. There's a rapid shortening. You hospitalize that woman and monitor in hospital for some few weeks because the dangers are too much. So once you have picked it up, women should be followed up routinely, and they should be educated that if they do experience cramps, they should rush to hospital or attend a clinic where they can be assessed, where their cervix can be checked to make sure there is no shortening of the cervix going on, because shortening of the cervix will result in the tears that normally the separation of the lower segment the separation of the membrane around the internal os, that is the potential to cause bleeding. Delivery, the delivery is by cesarean section 34 to 36 weeks. Our lady there, the one I showed you, she was delivered around 35 weeks. She didn't bleed, but we recommended that I think anytime between 34 to 36 weeks, she should be delivered because we're afraid that she would bleed if we continue beyond that. So around 30, I think it was around, it was close to 36 weeks, 35 something when she was delivered. And fortunately, we were successful. Both the mother and the baby were fine. There was no PPH that required attention then. However, the delivery depends on what will be happening to the cervix and also the bleeding. If the woman bleeds, they have to be delivered. Why? Because when the pregnancy is bleeding from vasa previa, it's not the mother bleeding, it's the baby who is bleeding. So babies do not have a lot of blood. So that even if they bleed 100 millimeters, they are close to exsanguination. They do not have a lot of blood volume. So any bleed from vasa previa is close to lethality, really, for the baby. Fetal death is more than 60% if not diagnosed prenatally. That is when membranes rupture. But believe you me, in our setup, this more than 60% is in Europe, whereby the decision to deliver time probably less than 10 minutes. But in our case, if we miss vasa previa, and these women present with bleeding, mortality approaches 100% here for the baby, the fetal death. Why? Because our decision to deliver and delivery time is more than 30 minutes. And we're talking of the baby bleeding, the baby who doesn't have lots of blood. So in our case, it is very vital that we pick up vasa previa in prenatally, because the fetal death will approach 100% if this woman going to labor and they rupture the membranes. If diagnosed prenatally, the mortality is less than 3%. In a center where I worked in the UK, from the case series that the center had for the prenatal diagnosis, the mortality was almost zero. They didn't lose any baby for all the cases that they picked up prenatally. So prenatal detection is very important. There's no increased risk of recurrence with this condition. So that is vasa previa. I think that's the case which I wanted to discuss with you today. It's a very short case. Maybe I will open the room for any questions or comments you want to make on the vasa previa case. Any comments to make on the vasa previa case? Any comments? But that's vasa previa. Remember it, and always remember that during the anomaly scan, actually starting first trimester, assess condensation on the placenta. The same way in second trimester, assess condensation. I think you have seen that we have added, I think it's now more than 2 years, when we added condensation on Fitamed. The reason why we added condensation on the placenta section is because we want to increase people's chances of detecting conditions such as vasa previa. Because if we are used to check the code, I think this is the reason why probably most people struggled to answer the question when we were asking, what is this image showing? Sorry, I want to play this video again. Oops. It's not. Yeah, there we are. So when I asked what we were looking at, I think most people struggled. The struggle comes from having a habit where you are not checking condensation frequently. If we are used to check condensation on the placenta, this shouldn't be a problem, because you can see here that the cord is inserting here on the posterior placenta, and that this vessel is running on the surface here, going to the other lobe, the other side here. So have the habit of checking condensation. Make sure that if you are the one entering information on the fetal med, you do not allow the scan to finish before somebody has told you where the code is inserted. They should be able to tell you how the code is inserted. Is it inserted marginally? Marginally, that means it's less than 2 centimeters from the margin. Then central is close to the center, it's far away from the margin of the placenta. Yeah, so check condensation and so that you are competent to demonstrate how the communicating vessels are running, because without being able to detect condensation, you also find it challenging to even pick cases of vasa previa. And remember, during your cervical length assessment, put on the color Doppler. The color Doppler will allow you to pick cases of vasa previa, which are where vessels are running across the internal os. Put on the color Doppler. This is why you have the color Doppler, to increase the detection rate of vasa previa, which occurs in 1 in 3,000 pregnancies, which is a lot in fetal medicine terms, because that means 100 cases, 100 something cases, which have the potential to kill babies per year in Zimbabwe. Imagine 100 babies dying from vasa previa per year. It's unimaginable. It's too much. So this is why we want people to know about it. Thank you. If there are no questions, I think I'll end the meeting here, unless if there are any questions or comments. But just remember vasa previa, very important. Thank you so much. So next week, we are going to have another case presentation from the midwives. They will present an interesting case they came across. So see you again next week for another case presentation. Bye-bye.